to uh, give to you a few insights about your own study. First of all, I'll start with the management of labor. I'll go with that for about half an hour, and then I will let you know about the 20 most downloaded or searched articles during 23 in obstetrics and gynecology. And thirdly, I'll let you know a few abstracts which I downloaded, which might interest you, which are of day-to-day practice and which also will be of use for the purposes of examination. So first, if we go to labor, actually, when we were talking about labor, yesterday, after having completed the subject, I had given my residents here questions to which I wanted them to, about which I wanted them to study and then respond in some way, right, or whatever. So I'll go through those questions one by one, not all of them, because in all there are 30 questions. Some are parts of the main question as it is, but we will look at those and the significance of those questions. Now, when we look at the process of labor, as I see, for the purposes of examination, labor management is not really a prominent subject that one would talk to, because you don't have a patient who is in labor placed in the examination. There may be a scenario, there may be just part of the management or in one or the other areas, but not as a whole, as the management of a woman who is in labor, starting from its diagnosis that she is in active labor or she is even in latent labor. From there, taking her to the process of delivery and finally completing that process so that she is in the postnatal ward, etc. Now, what I see and the need for that arose because I realized that when we talk about theory, respectful maternity care, labor care guide, and this is the partogram that we have to fill, and there are different 7 segments of that, and we look at those segments. How much do we actually practically put it into practice? That is one. Secondly, do we voluntarily or knowingly go through the process of those things, or we just do it to fill up that chart? Has it been the management of the labor, has it been inculcated within our reflexes of management so that we would be doing all that with every laboring woman without even realizing that or without recalling that this is what we need to do? So that is something which comes about automatically. You do it automatically, and like those things which you do in routine. Those of you who know driving and not the automatic type and the other motors in which you have to press the clutch and change the gear and then press on the accelerator and release the clutch gradually so that the vehicle starts moving. Now, those things first you learn, and then they just come about as a matter of fact, and you don't even think that this is what you are doing. You are not pressing upon the accelerator as like that, or you are not removing your foot from the clutch. So that is something which gets incorporated within your reflexes. So that is what my objective would be, that when you read about it, when you talk about it, when you practice it, this management should be part of your reflexes, that labor management. This is what you would do. And once you start doing that, as I gave the example of Professor Sohail, when he was preparing for his LCPS, that he had been trained and he bought the books only a month before the examination, so that he thought that he knew everything or he knew how to practice that, and that helped him. So there were this this is the list of questions, 16 on this page. How would you make a diagnosis of onset of labor? Once you make the diagnosis, what will you say to the patient? Now, if I ask, there will be different answers to that, but ask yourself, what will you tell the woman after you have made a diagnosis? Now we'll go to the diagnosis later on, but what do you tell the woman?
Starting with the saying that the labor has started, but still she's in latent phase of labor, and I'll tell her what latent phase is and how long it would take for her to go into.
Right, right. No, you see, actually, when you have to answer it like that, sitting here, you might be a little awkward at a loss of words. Something which should come automatically. You have examined the woman, you have taken her history. First, you introduced yourself, you've taken the history, and then you told her that you need to examine her. And you examined her and you found that the cervix is 3 centimeters, it's partly taken up. And you also saw that she was having regular uterine contractions of moderate intensity, and fetal heart is all right, and so that kind of thing. So now you tell her that you have to tell it in your own words. Now make and devise that phraseology that you will address the patient with. So anyway, these are 16 topics, and there is another set of 14 topics for the different position to deliver a patient, etc., etc. Now, what I did was, and that's why I got a little late, because I thought of it a little late in the morning about how to go about it. Then I have put the heading on a slide, but I haven't had the time to write down about each of these headings downwards. And this I leave to you. I leave this presentation to you with its heading, diagnosis of onset of labor. Now, what are the points that you do? What are the points on which you make a diagnosis? And those points are, while you will each one of you would do that, but I would base it on history. And when you say history, then there are those points that you would be making the diagnosis upon. So there will be history of, first of all,
Regular painful uterine contraction.
उससे पहले क्या होगा? हाँ? और
introduction of the patient.
So this is take of things, you would, because I am talking of labor, so you would think that it is the labor, the pains, labor pains, that it is gestational amenorrhea. What if she is just having abdominal cramps and it is not labor pains, but she is having some abdominal problem issue? So gestational amenorrhea, you have to qualify that the woman is pregnant. The history of gestational amenorrhea and her antenatal record, which will tell you about that. So this is the kind of approach that you need to develop. So this is the kind of approach that you need to develop when you start managing a woman or patient. So history of, now we are dealing with a woman who is in labor. And then she'll give you history of, because there are, what happens in labor, there are uterine contractions which result in dilatation, effacement of the cervix, and gradual descent of the head, etc. Those are the features. So after that, then you will examine and you will see the abdomen is large, and we are talking of labor at term. And then you, when you examine after having taken her history, amenorrhea, and she says that she is having these pains since or for the last 3 hours, and she's come to the hospital. She's a booked patient, and then you examine and you find that there are regular uterine contractions. Now, why regular uterine contractions? Yes, because the uterus starts to contract quite early on in labor. As a matter of fact, even in the first trimester, when you do ultrasound, the woman may not be aware of that, but I should these days use the term person. The person may not even be aware of those uterine contractions as painful, something painful happening, but you can see on ultrasound that there is an area of thickening, which initially you might mistake for placenta, but it's a little different and it's a localized area of thickening, and that is the contraction of the uterine wall. So contractions are there right from the early part of second trimester, but those are sporadic, those are irregular, those are not painful, and they sometimes occur after a short while, sometimes the interval is longer. So when the process of labor actually starts, then there is that change in the character of those contractions. And that starts to happen in the later weeks of pregnancy. They become more frequent, they become more intense, because of which they cross pain threshold and then they become painful. And this is what you actually, in the later antenatal period, you instruct the woman about, that you will have, if you have contractions like that, which are regular, which are, when you can predict, you have timed two contractions and you can tell now 10 minutes have elapsed and the next contraction is coming, and if she finds that it is coming, that means these are regular contractions. And they'll also, and the contractions, they start from the upper part of the abdomen, which is the upper part of the uterus, and spread in a wave form downwards. So those are the types of contractions. And if she gives you history that she started having regular, and then you examine, and by that time we assume that the cervix would have dilated a little bit, it would have effaced, its length would have shortened, it would be soft and all that. So that is there. And then she might present with rupture of membranes. But rupture of membrane sometimes occurs and there are no pains, there is no shortening, there is no effacement of the cervix. So that is part of that. But essentially it is the labor pains, contractions, uterine contraction, painful regular uterine contractions, and effacement, etc. So that is how you diagnose labor. And then, of course, the third thing, there may be show, usually, because when the cervix starts to open up, there is stripping off of the membranes. The membranes come a little bit, so there is release of a little bit of, there is bleeding, and that mixed with the cervical mucus comes out, and that is called show. The amount of that would be variable depending upon the size of the vessel which gets ruptured at that time. So, but it isn't really too much. So labor pains, effacement, and history. She can tell you on history that there may have been a little bit of bleeding or mucoid discharge. And then on physical examination, you find that this is it. So this is the diagnosis of onset of labor. Now, the next question is, once you make the diagnosis of onset of labor, what will you say to the woman? So you'll tell her that, well, you are at term, you reassure her, and the process of labor has started. And then you brief her about the process of labor, what will happen, how long it is going to last, and what should she expect, and how she will be taken care of. And the total approach in that has to be positive, helpful, sympathetic, so that she feels at home. Not necessarily at home, but she feels at ease. And last time I mentioned that many a times, if it is a priming gravida, then it is fear of the unknown. She doesn't know. She has been told that it is a painful process and it is something terrible, and she will be afraid of that. And if she is a multip, she previously has experienced it, so the previous experience may not have been such poor, or she has experienced pains. So she would be expecting the same kind of thing. So there is some element of apprehension associated with that at that time. So she will be like that. So you need to reassure her that everything appears to be normal. The heartbeat of the baby is fine. Your contractions are regular. They'll gradually become stronger. They'll become more frequent, and they'll become more effective. That they're becoming stronger and more painful means that they are going to be more effective in the process of labor by pushing the baby down and delivering. So don't be afraid of that. We have various means of pain relief which are available, and we'll give it to you as and when required. And it is entirely up to you to choose what method of pain relief do you want and when you want. So when you want that, we'll give it to you. So this is what you tell, and then you also tell her that we are here to assist you, to help you, to take care of you, and take you through the process of labor. That reassuring kind of conversation, and also that obstetrics does not or cannot be run by clock, and there is variable period of time. Sometimes the labor progresses quickly, sometimes it takes a little longer, depending upon how your system operates. But if there is undue delay, then we can always augment, and we can do things. Otherwise, we'll observe how you progress, and we'll not interfere unnecessarily. But during this time, and of course, now that you are in labor, you will remain in the hospital till your delivery, and you will go after delivery. And during this time, all that what I have briefed about, all those points, you need to then put them in a kind of chronological order, in that order, that how are you going to tell her. And well, that's about it. So during this time, we will continue to observe and see how your labor progresses, and if there arises a need for any kind of intervention, then we'll be doing that. And there is a likelihood of your having a normal delivery, but if something happens, then we inform you, and we'll act accordingly. So that kind of summary of what she is going to experience during that time, what the status of her situation is at the moment. That is one. Number two, how is she going to go through the rest of the process? How is she going to be taken care of? And how her concerns and her apprehensions are going to be addressed. So those are the things that you will tell. So these are the 4 points, let's say 4, 3, 4, or 5 points. One, briefing her about the status that she has come in, number one. Number two, how is it likely to progress? Number three, how you are going to manage her, and taking care of her requirements, and the timing, etc. Right. So this is what you tell the patient once you work. How do you nurse a woman in labor?
First of all, by reassuring,
Hmm?
then telling her about the diagnosis, and then making a plan, telling her about the management. Partners,
जैसे थे वो कंपेनियन की बात हमने की, वो तो नर्स का मतलब ये है कि इसमें व्हाट विल बी हर पोजीशन, उसका चलना फिरना उठना बैठना वो कैसा होगा, क्या आप हम बेड पे लेटा देंगे, हम उसको एनकरेज करेंगे टू बी मोबाइल, ये है नर्सिंग का मतलब, हाउ डू यू नर्स। और इसके साथ इसमें और एलिमेंट भी आ जाते हैं जो कि हमने वी पुट इन लेटर इन वेरियस, उसमें caloric requirement or pain relief or care of bladder and bowel and all that. So essentially, if we just confine ourselves at this point to the position in which we are going to have the patient in. Well, she can be in any position that she feels comfortable. She can be up and about, she can move around, she can lie down on her side. And generally, it is advisable that you tell her that you lie on your side to avoid compression of inferior vena cava. And well, that's about it. So that's how you nurse it. The rest of the things would come in. How will you take a woman through the process of labor, first stage of labor? So you the rest of the things which are coming ahead will be part of that. So you you would monitor the progress of labor. You would monitor the fetal well-being. You will monitor her caloric requirement, care of bladder and bowel, her position, her lying down, moving around, periodic pelvic examinations, and reassurance. So that's what you do and see that the labor is progressing in a normal fashion. Monitoring of labor. So how do you monitor the labor? You monitor the labor, bolo. Essentially, monitoring labor का एक पहला सवाल जो जवाब आप दोगे वो है partogram. You are maintaining a partogram which would show the intensity of the contractions, which will show the dilatation and effacement of the cervix, which also will show the descent of the presenting part, which is vertex. And that's how the labor is monitored, because the progress of labor, the features of progress of labor are regular uterine contractions, which are moderate to strong in intensity, and gradual effacement and dilatation of the cervix and gradual descent of the vertex. These are particularly those points relating to the cervix and the presenting part. They are relevant to progress of labor. And when you monitor, it is not only monitoring of uterine contractions, and this you also monitor the fetus. So essentially, monitoring of labor is the composite form of that is maintenance of the partogram. So you start off your answer. If I ask you, how do you monitor labor? Partogram. You maintain a partogram, right? And after having said that, you give a little pause. A good candidate in the examination. Now we'll take also into consideration the examination aspects of that. So we monitor the labor by maintaining a partogram, which is the recent labor care guides by WHO, which are a comprehensive charting of the progress of labor. And in that, we see the character of contractions, the gradual dilatation, effacement of the cervix, gradual descent of the presenting part, and also the fetal condition. And whatever is required during that time, that also is noted and that is charted, right? So you say partogram, and then वो जो सात चीजें हैं उसकी starting from the details, उसकी identification details से लेके तो नीचे तक of वो जो है कि मैनेजमेंट विद कंसेंसस और विद शेयर्ड डिसीजन मेकिंग, ये आजकल के वो जो टर्मिनोलॉजी है उस तक वो सात एलिमेंट बनते हैं, वो फर वो केयर ऑफ नहीं होना चाहिए, केयर ड्यूरिंग लेबर, केयर ऑफ द वुमन, एक्चुअली केयर ऑफ द वुमन था, मैंने वो काट दिया, तो केयर ऑफ द वुमन, फ्लूइड एंड कैलोरिक रिक्वायरमेंट। ना आप मुझे सच सच बताओ कि आप लोगों को अब 2-2, 3-3, 4-4 साल होने वाले हैं, आपने कभी इसके बारे में वैसे सोचा कि ये लेबर में है, इनकी क्या जरूरत है? How many times have you, after having examined the woman, detailed her or told her about the process of labor or kind of reassured her? बताते हो? उनको समझाते हो कि ये आप इस तरह से, लेकिन ये वाली चीज जो है इसको
सर इसमें हम कहते हैं एडिक्वेट हाइड्रेशन रखें और लाइट डाइट लें।
What do you mean by adequate hydration?
ओरल जितना भी आप ले सकती हैं।
नहीं सर, लेते थे नहीं, ये adequate hydration ये जरूरी नहीं, आपने कहना कि जितना आपको जरूरत है, आप प्यास महसूस करें तो आप पानी ले सकते, क्या क्या ले सकते हो? जी
सर यूजुअली लिक्विड्स लेंगे और सॉफ्ट डाइट लेंगे।
सॉफ्ट डाइट से क्या मतलब है?
हम कहते हैं हल्का सा सैंडविच लेंगे, लाइट
हल्का सा सैंडविच क्या मतलब है? हम पहले कह देते हैं सॉफ्ट डाइट, फिर कहते हैं हल्का सा सैंडविच है, वो सैंडविच में चीज भी पड़ा हुआ है, तो वो you have to be specific about that. So what can she take, right? So depending upon, अगर उसको वॉमिटिंग हो रही है फिर कुछ और करोगे, अगर वो है और फिर एनेस्थीसिया की रिक्वायरमेंट हो सकती है। Now this is the point over which there is quite a bit of confusion. There would be some people who would be saying, Kedi, because she might need anesthesia at short notice, and she, और फिर ये है कि during labor the gastric emptying time gets prolonged. वो prolonged हो गया, जो कुछ खाएगी वो उसमें पड़ा रहेगा, and if she needs general anesthesia, then वो aspiration syndrome हो जाएगा, तो फिर क्या करोगे?
स्मॉल पोर्शंस
Small portions, आधी रोटी खा लो, वन फोर्थ ऑफ पिज्जा, पर्सनल साइज का जो पिज्जा उसका वन फोर्थ साइज, वुड दैट बी ऑल राइट?
फास्ट फूड तो नहीं कहते।
नहीं, फास्ट फूड नहीं है, पिज्जा इज नॉट अ फास्ट फूड, मतलब वो जो है फास्ट फूड की वो उसमें ना जाओ जो कि रेडिली अवेलेबल है, नॉट दैट। तो और क्या,
तो कुछ फ्रूट्स ले सकती है,
कौन सा फ्रूट ले लें?
एप्पल ले सकती
हैं?
है, banana ले
ये देखो ना, प्रैक्टिकल वाली बात करो, कौन सा हम फ्रूट देते हैं? कभी देखा है किसी को फ्रूट खाते हुए? हाँ।
सकती है।
नहीं तो वो नहीं है आपकी मकसद, क्या क्या वो कहे जी मैंने तो वो देना है, वो किनू खाना है। वो ऐसा नहीं है, यू यू हैव टू बी स्पेसिफिक, ये ढूंढो जाके, ये सारा कुछ मैंने नहीं बताना। व्हाट काइंड ऑफ फूड वुड यू अलाउ एंड इन व्हाट क्वांटिटीज, बी प्रैक्टिकल। ये देखा तुम कहते हो हम पेशेंट का बड़ी केयर करते हैं, देखते हैं, फ्लूइड की अमाउंट की आप जितना मर्जी पी लो, आप उसको वो ये इसका ढूंढ के ये मुझे बताना, ये सारे बाकी भी जो सुन रहे हैं वो भी करें। व्हाट इज द इम्पोर्टेंस ऑफ केयर ऑफ ब्लैडर एंड बाउल? बाउल की केयर जो है आजकल उसके बारे में इंडिफरेंट है, बट आई वुड प्रिफर कि पेशेंट को एनिमा, इसके बारे में भी देयर आर वेरियस कंसिडरेशंस है। कई किताबों में आपको देयर इज नो नीड फॉर एनिमा, अमेरिकन एनिमा वगैरह के खिलाफ, बट आई वुड रादर दैट द वुमन शुड बी गिवन एन एनिमा, बट इफ द मेम्ब्रेन्स आर नॉट रप्चर्ड एंड शी कम्स इन लेबर, उस वक्त एनिमा दे के rectum को empty कर लिया जाए, because at the time of delivery, to prevent or avoid or minimize soiling of the area, because you are going to, or the delivery is going to take place quite close to the anal area, and if and many a times we do see that there is considerable soiling of that area, which of course would affect the whole process. So वो वाली चीज है, so उसके लिए secondly, enema देने से थोड़ी सी वो, because of some disturbance of the lower bowel, there is also a reflex improvement in the uterine contractions, but not for that purpose. Enema is to empty the bowel so that there is less soiling. And care of bladder, and particularly if the woman has had an epidural analgesia, because in that case the bladder will be kind of atonic, and she may not realize that bladder is full. And thirdly, that also hinders progress of labor if there is a full bladder. And at every examination, which should not be too frequent, जैसा कि लेबर गाइड में लिखा हुआ है कि आप 4 घंटे के बाद करोगे, तो उसमें आप क्या देखते हो कि ब्लैडर अगर फुल होगा तो हेड ऊपर रहेगा और हेड वो नीचे नहीं जाएगा, और उसके बाद अगर वो हेड थोड़ा नीचे चला गया तो फिर ब्लैडर फुल होने का इम्कान है। इसलिए कि the woman might find it difficult to empty her bladder on her own, वो जाने का। So इसलिए be on the lookout for that bladder is not excessive, that she is passing urine when there is desire, number one. Number two, periodically आपको कुछ यहाँ पे कई दफा हो जाता है, पूरी पूरी रात गुजर जाती है और पेशेंट ने यूरिन नहीं पास किया होता, तो सुबह जाके पता चलता है, और फिर आपके एक्सरेज करते हो तो 1300 ml यूरिन आ जाता है। वो that is something which gets neglected in that fashion. So there you should know the bladder and bowel are empty as far as possible. तो वो उस तरीके से देखोगे। Fetal monitoring, of course, that's part of the
Sir,
whole process.
sir, excuse me, sir.
हाँ जी।
Sir, then what should we do for the fluid and this requirement?
ये मैंने कहा ना कि
Is
ये
it,
आप जरा किताबों में देखें और देख के मुझे अगली दफा बताना है आपने सब। फ्लूइड की रिक्वायरमेंट भी बतानी है, और एडिबल्स जो हैं वो भी क्या क्या खा सकती है पेशेंट, और अगर वो वॉमिटिंग कर रही है तो फिर हाउ आर यू गोइंग टू रिप्लेनिश दैट। फिर कंपैरेटिवली आपके लिए सिंपल हो जाता है, फिर तो आपने खाना पीना बंद कर दिया और उसको आईवी ड्रिप दे देंगे, फिर मुझे वो आप बताएंगे कि आईवी ड्रिप क्या चीज की देंगे ना। आइसोटोनिक तो दोगे तो उसकी वो तो आइसोटोनिक हो गया, ग्लूकोज कितना दोगे? 5% दोगे, 10% दोगे, 1 ड्रिप दोगे, 2 दोगे, 3 दोगे, वो। सो टेल मी समथिंग अबाउट दैट। तो मैं साथ साथ तुम लोगों के लिए भी सवाल छोड़ के जा रहा हूँ। नहीं, रिंगर आप जो देते हैं मुझे वो ना बताओ, देना क्या चाहिए? व्हाट अकॉर्डिंग टू व्हाट? नहीं, बीएसआर मॉनिटरिंग करने की अगर वो, ये नहीं है, इस तरह से बात नहीं। तो उसके मुताबिक टाइट्रेट करते हो कितना नहीं। We are not talking of a diabetic woman. We are talking of a woman who is non-diabetic, average, without any complication. ये जाके देख के बताओ मुझे, जो देते हो मुझे उससे गर्ज नहीं है, जो देना चाहिए मैं उससे पूछना चाहता हूँ। फीटल मॉनिटरिंग, फीटल मॉनिटरिंग के क्वेश्चन जो है, मैं अब मैं इसकी डिटेल में नहीं जा रहा। वो ये है कि व्हाट आर द मेथड्स ऑफ फीटल मॉनिटरिंग, what is the frequency with which you should be doing it, and what is the purpose of this, what is the importance of fetal monitoring in the process of labor. Or important, what are the pitfalls of electronic fetal monitoring. वो एक सवाल से देखो कितने कितने सवाल निकलते हैं. And do you think electronic fetal monitoring has contributed to increased incidence of cesarean section?
Yes.
इसको मैं थोड़ा सा लफ्ज़ एक ऐड कर दूं, unnecessary increased incidence of cesarean section, which means that if we are not very well versed with, or we are not well versed with interpretation of CTG, then वो थोड़ी सी फ्लैट होगी, हाइड्रेशन कर दो इस, ये जरा इसका भी जरा रेफरेंस ढूंढना, यदि फ्लैट आ रही थी हमने हाइड्रेशन कर दी है और उसके बाद फिर सीटीजी ठीक होगी, कहीं पे है हाइड्रेशन करोगे तो सीटीजी ठीक हो जाएगा. सो ये क्वेश्चंस हैं, इनके मुझे आंसर, इनकी आप ये आपस में डिस्ट्रीब्यूट करोगे और एक एक स्लाइड बना के लाओगे, ये फ्लूइड और इसकी, बल्कि ये मुझे आप आज वेंसडे, मुझे संडे तक मुझे ना ये भेजोगे स्लाइड्स.
ईमेल कर दो.
नहीं, मुझे वो DHL से करना पार्सल. फीटल मॉनिटरिंग के बारे में और कोई सवाल? एसेंशियली यही है ना, आपने देखना है कि उसकी हार्ट बीट ठीक है वो, और हाँ, व्हाट आर मेथड्स ऑफ फीटल मॉनिटरिंग, वो मैंने क्या क्या है वैसे. पहले नंबर 1 पे क्या है? गुड, शाबाश. अब मैं यही पूछना चाह रहा था कि पहले तो आप वो ऑस्कल्टेट करना आता है.
सर
फीटल बैक पर पेट करके
अब तो लाओ मॉनिटर लाओ, वो लग जाता है तो वो उस तरह से वो करके, और फिर क्या करते हो?
सर बैक साइड पे,
हाँ.
उसके बाद सर बैक पे इसको रख के तो शोल्डर
लगा के
तो सर उसको 1 मिनट के लिए सुनना होता है.
वो, और वो इम्तिहान में अगर हो तो घड़ी भी सामने रखनी है,
Yes.
उधर ही ना ऐसे ही करना, और उठ के कह दो 120 पर मिनट.
Then
That is-
1 minute after every contraction in latent phase for after 15 minutes.
आफ्टर एवरी कॉन्ट्रैक्शन, फिर
No,
तो
sir, not every. After contraction for 1.
मैंने कहा आफ्टर कॉन्ट्रैक्शन, एवरी कॉन्ट्रैक्शन है, फिर तो सर लगा के उधर ही.
Sir, after 15.
फ्रीक्वेंसी भी उसकी. और फिर साथ में you have to be more practical that those places where electronic fetal monitoring is available, that आजकल वो हो गया है काफी सारा, but you should know again, this is a resource constrained country that we are working in, and this hospital particularly has all the facilities which may not be available in most of even the other tertiary care hospitals. The number of monitors, fetal monitors which are available here may not be available in tertiary care hospitals. लेकिन वहां पे भी आप इस तरह से करोगे, so therefore you need to familiarize yourself with how to do it. And in examination setting, if you have the occasion where you have to do this, then you should be able to use even Pinards, or you can use a stethoscope. I often used a stethoscope to listen to the fetal heart. तो वो उस तरीके से करके वो किया जा सकता है. Pelvic examination during labor. How frequently? Huh?
4 early in first phase.
But 4 hourly भी 4 hours से ज्यादा frequently करना मुनासिब नहीं है. हम करते हैं ऐसा.
Okay, sir. According to the need, sir, if patient says.
According to the need of the woman or the doctor,
Need of-
मैं भी करके देख लेता
No,
हूँ कि
sir,
क्या
according to the need of the woman.
वही
Sir,
हाँ कम कर दिया ना वो जब से लेबर केयर गाइड जरा देखिए तो
जी, sir,
so this is how it affects your practice so that you know, and you know you must remember that every pelvic examination is an awkward, to say the least, but it's an unpleasant and many a times a painful experience for the woman. So you have to be sensitive to that. And अब question यहाँ पे ये भी आता है how to cover and how to expose the woman at the time of pelvic examination. May that be gynecological, may that be during labor. So one is that privacy has to be ensured. Privacy हो, वो area जो है वो walled off हो या curtained off हो. And then remember, for pelvic examination, because this is what we are talking about, pelvic examination के time पे, if the woman with her legs flexed, if her knees are covered, then she does not feel unduly exposed. वो जो होता है ना ये कि इधर भी कवर नहीं है वो नहीं है मैं तो वो देखता नहीं वो उधर से अगर गुजरे के जी पर ठीक है वो अभी पेशेंट को चादर लेने गई जब तक चादर आएगी इवन अप टिल दैट टाइम there is absolutely no excuse for the woman to have her knees uncovered or exposed, right? Until and unless वो कोई और जरूरत है किसी चीज की तो उसके वजह से जैसे आप प्रेपरेशन कर रहे हैं या वो उस तरीके से कि under anesthesia an awake woman should not have her knees exposed and they must always be kept covered और साइड तक हो adequate size की आप वो शीट इस्तेमाल करोगे उसके लिए and then ask the woman if she has emptied her bladder. It's better to have वो एग्जामिन करने से पहले आप जो लेबर में एग्जामिन कर रहे हो इवन गायनेकोलॉजिकल एग्जामिनेशन में जब आप वो देख रहे हो तो लेबर वो ब्लैडर शुड बी एम्प्टी तो अभी हम लेबर वाली बात ही कर रहे हैं एंड रिमेंबर ऑलवेज ये मैं तो अभी भी सिंगल डिजिट एग्जामिनेशन करता हूँ आप जो वर्चुअली भी सुन रहे हैं प्लीज पे अटेंशन टू दैट single digit examination gives you quite adequate information. That information which you get at the expense of pain to the woman, that is not really required. That's not on. वो ये है कि वो पकड़ के तो वो जोर से जी हमने जाके देखना not on, absolutely not on. वो नहीं है. That's unnecessary invasion, undue invasion of फिजिकल इन्वेजन वो नहीं होना चाहिए सो लेकिन अगर एपिड्यूरल लगा हुआ है मल्टीप है एंड देन ऑफ कोर्स यू कैन जो इंपॉर्टेंट चीज है वो ये है कि देन यू स्वैब विद सेवलॉन एटसेट्रा that swabbing actually should not be just over the external genitalia. If you do that, then you are soiling it. You are spreading that for its entry into the vaginal canal, or now we can call it birth canal. So what you do is that you separate the labia, and what is exposed is anteriorly there is the vestibule and then the introitus. So you take a swab and you move it from before backwards. And once it goes backwards, then it goes out. You don't do it again and again. And generally, ये निश्तर में जब मैं रजिस्ट्रार था, सिस्टर मुझे करवाया करती थी, वो और पीवी ट्रे आती थी पीवी ट्रे में ग्लव्स उस वक्त ये प्री स्टेरलाइज्ड ग्लव्स का एक लिफाफा सा बना होता था कपड़े का जिसमें स्टेरलाइज्ड ग्लव होते थे एंड देन यूज्ड टू बी एटलीस्ट 3 स्वैप्स दैट ट्रे और उसके साथ हम पेल्विक एग्जामिनेशन करते और वो उसमें यही जिस तरह से मैंने बताया कि सेपरेट एंड देन मूव द स्वैप फ्रॉम बिफोर बैकवर्ड्स एंड आउट 3 दफा ऐसे करके Now that would reasonably adequately clean the introitus where you are going to place your fingers in. And of course, you do it with sterile gloves. Now, what you do is that you place your finger on the fourchette, which is the posterior boundary of the introitus. And if you place your finger there and then you press that even a little bit gently, then it does not really cause pain or discomfort to the woman. Even those girls who come complaining of vaginismus and who have vaginismus, when I examine them, I let them guide my finger into the introitus, and there I stop for a little while, and then I press at the perineum, and I tell them I'm going to press it a little bit, and you will not feel pain. And nobody really feels pain until and unless, of course, there is some injury, or if you are examining her after an episiotomy, which is not properly healed as yet. उसमें वहां पे होता है. Otherwise, an intact perineum would not really result in. And as a matter of fact, by pressing that, the rest of the pelvic muscles, they become a little relaxed. So they facilitate your examination. And then you guide your fingers, or you glide your fingers along the posterior vaginal wall. Posterior vaginal wall with the fingertips towards the pelvic brim with an angle of about 45, so that you are going towards the pelvic brim. That is where the cervix of a laboring woman would be, right? Because it will be in the middle, central. Cervix is said to be central. तो वो उस तरीके से आप ये pelvic examination वो करो. और वो जो gynecological examination उसमें आपका दूसरा हाथ जो है वो abdomen में from the navel downward जाएगा. तो उसकी बात है, ये pelvic examination उस तरह से करना, और वो and if the woman hasn't had an epidural या वो नहीं मिला हुआ, so then you have to be gentle again while you are examining the cervix, or you are trying to kind of stretch the cervix, or you are trying to sweep the membranes. तो वो भी उस तरीके से कि वो pain ना करे. It of course will be uncomfortable. So just before you do it, you tell the woman that I'm going to examine you. It should not be painful. It will be a little uncomfortable. It will not be painful. And if you feel hurt, and if you are hurt, please tell me, I'll stop there and there. That would be, or those would be the stock sentences that you will talk at that time. I'm going to examine you, or I'm going to examine you with a speculum. It should not hurt, and it will not hurt, but if it does, tell me, I'll stop. There is no point in just pushing the speculum, the woman crying and all that, etc. वो वाली चीज जो है वो on नहीं हो. ठीक है, 9:30 हो गया. मैंने तो 2-3 चीजें और भी बतानी थी. डॉक्टर साहब, डॉक्टर राशिद का सेशन शुरू होने वाला है जी. अच्छा, मैं जो 2 चीजें कहने लगा था, एक तो ये है कि इफ यू गो, मैं इसको हम यहाँ पे छोड़ते हैं और आगे चलेंगे. मैं आपको जो चीज बताने लगा था वो ये है, ये देखो, ये लिस्ट है. ये शेयर मैं कर रहा हूँ स्क्रीन अभी के नहीं है. शेयर करें सर. हाँ, मैं शेयर करने लगा हूँ. ये है टॉप पेपर्स फॉर 2023 ऑब्स्टेटिक्स एंड गायनेकोलॉजी. ये हैं 20 पेपर्स हैं. Polycystic ovaries, preeclampsia, low dose aspirin for preeclampsia, oxytocin physiology, pharmacology, new technique to preserve the uterus in patients with placenta accreta, preeclampsia, recent advances, recommendations for evidence-based guideline for assessment and management of PCO, active phase of labor, repair of episiotomy and obstetrical perineal lacerations, pathophysiology, fetal heart tracings in clinical practice, efficacy of misoprostol dose 25 to 50 micrograms, meconium stain amniotic fluid, prevention of perineal trauma, latent phase of labor, current guidelines for diagnosis PCO. ये है ovulatory disorders, FIGO classification, intrauterine device management, postpartum hemorrhage, technique for managing impacted fetal head, placental abruption, overview of ectopic pregnancy, progesterone for women with threatened miscarriage. No role at all. They stopped the study. There's no point. As a matter of, in the group that they gave progesterone, the pregnancy rate was, continuation rate was lesser, slightly 2% lesser than the placebo group. Antenatal corticosteroids and update assessment of anticipated benefits and potential risks. Management of hemorrhage shock, long-term outcome of hysterectomy with this systemic review, endometriosis, adenomyosis, recurrent miscarriage, staging of endometrial cancer, pharmacological, ये तो काफी सारे हैं. Preterm birth, efficacy, safety of metformin, timing of delivery of for twins, hypertensive disorders, metformin, aspirin in pregnancy, women with abnormal uterine bleeding. Great. And most of these articles are available.
आप शेयर लिंक कर दें
लिंक क्या तुम लोग ये जाओ इसके ऊपर, ये क्या है ऊपर क्या लिखा हुआ है, ये मेड्सकेप पे है, ये उसके लिए करके QX ये है QXMD है, ये इसकी एप्लीकेशन मिलती है, उस पे फोन के लिए भी मिलती है. ये है टॉप पेपर्स, इसमें आएगा एक्चुअली, ये है इसमें आता है पहले वो काफी सारी चीजें ऑब्स गायनी के सब्जेक्ट में आप चले जाओगे, बट यू कैन गेट दैट. इसमें कुछ पेपर्स जो हैं अवेलेबल होंगे तुम्हें. इसमें से मैंने 2-4 पेपर्स डाउनलोड किए, वो बाद में मैंने देखा तो मैंने ऑलरेडी डाउनलोड किए हुए थे पहले, लेकिन हैं इसमें कुछ हैं, और वो इसके लिए जो चाहिए होंगे हम देख लेंगे. एक तो मैंने ये करना चाह रहा था, दूसरा मैं आपको ये बताना चाह रहा था कि मैंने ना अब एक और प्रैक्टिस शुरू की.
डॉक्टर साहब भी आ गए
हैं?
डॉक्टर राशिद साहब भी आ गए.
अच्छा चलें, बस मैं खत्म कर रहा हूँ.
नहीं तू बोल बोल.
अच्छा, मैंने ये किया है कि मैंने ये ना कुछ एब्स्ट्रैक्ट्स जो हैं वो डाउनलोड करके, तो वो मैं उनको, ये मैं आपको दिखाता हूँ क्या मैंने वो उनका इस तरह से करना शुरू किया. ये जो है maternal vaccine effectiveness against influenza, और ये कि how that vaccine provides protection to infants also for 3 months. आप vaccination influenza की दे देते हैं. It's important because influenza, you see, we do not take it seriously, but it is a serious thing. And influenza vaccine can be given to pregnant women at every stage of pregnancy, even in first trimester. And it was seen that for 3 to 6 months जो है बच्चों में वो उसका है. फिर है impact of adenomyosis on IVF outcome in women undergoing donor, वो but एक donor का जरूरी नहीं है, अपना भी उसमें जो है adenomyosis का effect जो है उसका क्या है. This study demonstrates that while adenomyosis did not significantly reduce the odds of implantation, the direct signs of adenomyosis, so इस तरह से चलता है. फिर है effect of acute histologic chorioamnionitis, ये premature rupture of membranes पे, on bronchopulmonary dysplasia and mortality rate among extremely low gestational age neonates. हमारे पास आ जाते हैं 26-27 weeks पे ruptured membranes के साथ. एक patient आजकल है, वो she is into her 3rd week with ruptured membranes and she is going on all right so far. But there is this kind of issue that can happen. And then this ये study है human reproduction की, progesterone for women with threatened miscarriage, a placebo controlled. इसके में अगर देखो उन्होंने स्टडी पहले बंद कर दी थी क्योंकि वक्त से पहले, because they thought that it was not useful. The live birth rates were 82.4% and 84.2% in the intervention group and placebo group. Placebo group में 84% और उसमें 82%. So therefore we need also to educate, but at the same time, generally I will still prescribe Dufeston for threatened abortion, because no explanation that I will give to them about this study or the others will convince the patient or the family. So therefore, when we practice, when we deal with the women, so long as examination is concerned, so long as the academics is concerned, we need to realize this. But we should not go overboard by prescribing lots of progesterone by mouth, by suppository, by injection, all that, because we know that they are not going to make that kind of difference. And therefore we give something कि जी हाँ हमने आपको ये दे दिया है और इससे अब बेहतरी की उम्मीद. So ये उस तरीके से ये practical point. Thank you very much, sir, for these 8-9 minutes.
नहीं तो इतनी बैठा लो. ये कोर्स में फर्रुख साहब और मैं दो मेन स्पीकर्स हैं, हम एक ही दिन आपकी क्लासेस लेते हैं। अब हम दोनों का जो फोकस है टोटली फर्क है और आपको दोनों ही बड़े इंपॉर्टेंट है। पहला फैक्टर तो यह है कि फर्रुख साहब आपको जो लेटेस्ट जर्नल्स में छपता है, लेटेस्ट इंफॉर्मेशन है हमारी प्रैक्टिस की, वो बताते हैं। वो उतनी ही इम्पोर्टेंट आपके लिए जितना कि बेसिक्स। तो इसलिए ये जो रेफरेंसेस दे रहे हैं, जो बातें बता रहे हैं, इन्होंने बल्कि आपके लिए कितना आसान कर दिया, कंक्लूजन और रेलेवेंस को हाईलाइट भी कर दिया है। आप टॉपिक निकालें, मैटरनल वैक्सीन इफेक्टिवनेस, और इनकी हाईलाइटेड पढ़ लें, आधा मिनट नहीं लग गया। इससे ज्यादा आपकी स्पून फीडिंग नहीं हो सकती। आप ये आदत बनाएं कि ये जो बता रहे हैं आपको, आपने डाउनलोड करके उन बातों को देखना है। और ये जैसे मैंने कहा, हार्डली हाफ ए मिनट या ज्यादा से ज्यादा 5 मिनट, बट देन यू विल बी विद इट। मैं अभी जब फर्क आपको बता रहा था, मैं सोच रहा था इसकी और मेरी प्रैक्टिस में क्या फर्क है। आजकल ये नंबर 1 हो गया, हम कहीं पे भी नहीं। और वो उसकी वजह मुझे आज समझ आ गई कि इसका इंफॉर्मेशन विच ही गिव्स टू द पेशेंट्स इज द लेटेस्ट। जो रात को छपी है वो आज बता रहा है उनको। तो पेशेंट की सेटिस्फैक्शन, आजकल हर कोई गूगल करता है, हर कोई पढ़ता है। तो जब ये उनको बताता है कि ये लेटेस्ट तो ये है जो तुमने भी नहीं पढ़ी। और मैं बेसिक्स, क्योंकि मेरी एज है, मैंने सारी उम्र प्रैक्टिस वो की है, मैं वही प्रिंसिपल्स, वही बातें वही करता हूँ। नॉट रॉन्ग, नॉट रॉन्ग, perhaps generally we are practicing what I am telling you, लेकिन आपको इम्तिहान के पॉइंट ऑफ व्यू से, और इफ यू विश टू बी wherever you are going to be number 1, then be फर्रुख, then be फर्रुख। और ये आप, तभी मैंने फर्रुख से कहा कि नहीं, यू गो ऑन। और वरना मैं एग्जैक्टली 9:30 पे शुरू कर देता हूँ, बट आई फाउंड दिस वाज इम्पोर्टेंट टू हैमर इनटू यू कि ये 2 लेक्चर्स हैं, एक ही सुबह में होते हैं। एक का ऑब्जेक्टिव क्या है? टू अपडेट यू, अपडेट यू। सो अपडेटेड डॉक्टर जो है वो हमेशा ही अच्छा होता है, हमेशा ही अच्छा होता है कि बाबा ये तो जो अब बातें हो रही है वो इसके पास है। सो कीप योरसेल्फ अपडेटेड। और ये फर्क की जो बात है, इसको अपना लीजिए, इसको अपना लीजिए। इसको बस आपने करना है, सारी उम्र ये करना है कि यू आर गोइंग टू अपडेट। अभी तो फर्क की असिस्टेंस अवेलेबल है, हेल्प अवेलेबल है। बाद में जो भी है, जहाँ से ये इंफॉर्मेशन मिलती है, निकाल के, जैसा इसने कहा कि टॉपिक लीजिए, एब्स्ट्रैक्ट पढ़िए और उसमें कंक्लूजन पढ़िए। आप बेशक पूरा पेपर ना पढ़े, बेशक पूरा पेपर ना पढ़े, और लेकिन ये अंदाज जो है, इट विल कीप यू अहेड ऑफ अदर्स, इम्तिहान में भी, प्रैक्टिस में भी। So I can't emphasize more on this. Farrukh, thank you for joining me. I'm so glad I got you at the tail end of your talk. लेकिन ये पॉइंट जो है मैंने बनाया है, आप भी इनको बार बार कहते रहिए, दोहराते रहिए कि बाबा देखा तुमने, कैसे रैंडम पूछो ना इनसे कि तुमने ये कौन सा एब्स्ट्रैक्ट देखा, कौन सा टॉपिक पढ़ा, ताकि इनको थोड़ा स्टिमुलस मिलता रहे।
Right.
थैंक यू सर।
Thank you.